Hello, good evening, everybody. This is the debrief of the session I had with one of my candidates. We discuss each and every station at length. I have also included in the white board the various comments made by the candidate and so on and so forth. Let us start with the communication one, which was a case of pyloric stenosis. The question was to discuss mom's concerns about urgent surgery because the mom was told that there was no bed available for transfer to a tertiary setting for at least 48 hours. So the candidate made good introductions. The only problem was the question on whether the pyloric stenosis can return after a successful surgery. I think factually speaking, it can, but the candidate said very clearly it won't. The ending summary was to arrange a second meeting. To summarize well, leaflets were not offered, consultant was not mentioned. The candidate did say that they would recheck the information and revert if needed, but this was not about the question regarding the recurrence. So the candidate thinks he might have just passed the station, but they're worried about giving away the factual error. The second station was communication 2, which was to talk to a mom who's brought her child to the ED the previous night for a accidental fall. The child was critically well and therefore was discharged after some neuro-obs. But mom was then called the next day to the CAU after a fracture was discovered on the X-ray. The station went well. The candidate says that he did discuss the NICE guidance and mom was still a little upset. He said he did say that the department would investigate the matter and they would learn from the experience, but the word pulse was not offered. The candidate is confident that they might have passed. The third was the history-taking session, which was an 8-year-old boy with a 6-week history of headache with space-occupying lesion type of symptoms and a new development of a neurological problem in the form of clumsiness. The child had been previously fit and well, full-term normal delivery. Everything was asked, including puberty, household, socioeconomic, and so on and so forth. From the point of view of the headaches, most of the Socrates symptoms were covered, but the red flags around space-occupying lesion were not covered completely. However, because of the history of a new neurological symptom, the diagnosis offered was around a space-occupying lesion. So the candidate is confident, or rather feels that he will pass. The discussion was around investigation, including CT scan, MRI, calling the consultant, involving a neurosurgeon and an oncologist. So that was that. Next was development station, which was the 3-year-old boy on which he was asked to examine social and speech milestones. Both of them were delayed, and on a historical basis, fine motor, gross motor, and cognitive milestones were also delayed. So the child was globally delayed according to the candidate. The etiology offered was from the history of neonatal jaundice, the possibility of an untreated kernicterus. This was a family who was a refugee. The delivery was at home. The child ate with his hands, and there was a lack of antenatal and postnatal care. So this was offered as a part of the diagnosis. However, the candidate did not think neglect was a factor. He thought that the history-taking station went fairly well and he passed. The next was a video 1, which was a video of a child with a large bruise on his left leg and left elbow, and particularly on the right leg. He thought it was ITP because the child was clinically well. Differentials offered were ITP, leukemia, and hemophilia. In the management, FBC, blood film, and biochemistry were offered, but clotting screen and LDH was missed. And mainly the treatment was around monitoring the child, safety netting from limiting physical activity, and so on and so forth. Personally, I think this looks like a little dicey one because usually ITP will cause multiple bruises and petechiae, yes, and child will be clinically well. So it is a tenable diagnosis. Hemophilia, I don't think was a tenable diagnosis in this child, but you never know. It could be von Willebrand also. Video 2 was a nephrotic syndrome, and this was a child with periorbital edema and pitting edema of the legs and also ascites. He was asked about the criteria for diagnosis, line of management, asked about the correct steroid doses and duration, etc., and what to do if there is no response. He did mention monitoring of hypovolemia and blood pressure. Now we come to the cases. So the CVS was a case of an 8-year-old child with a midline sternotomy scar and some drain scars on the chest. The candidate said that they spent too much time on pulses and JVP and etc., and therefore missed auscultating the heart. This will make this a little difficult station to pass because the examiner, I mean, he did ask the examiner whether he can auscultate the heart on the completion of the 6 minutes. The examiner looked to the senior invigilator who was also present in the room, who said no, that could not be allowed as the time was up. So management questions were around investigations. He offered a 2D echo and mentioned in the diagnosis that this is most likely congenital heart disease, but that's about it. The next was a respiratory case. This was a 3 to 4 year old child with a tracheostomy and a PEG. The chest had nothing but transmitted sounds. There were syndromic features, but the candidate could not identify the syndrome. The findings included dysmorphic features. Differential diagnosis included X preterm and mentions the unsafe swallow. The child appeared a little small. The examiner asked about the management and asked a specific question about what should this child have at home. The candidate, however, ran out of time, but mentioned about spare tracheostomy tubes, etc. And he also mentioned about open access and training of tracheostomy change, trachea tubes change. However, he did not mention about home oxygen and did not mention about suction. The next was GI and abdomen. This was the 11-year-old African girl with sickle cell anemia, which is a diagnosis that looks a little difficult because this child had a 3 to 4 centimeter liver, just palpable spleen, no pallor, and missed icterus. So other differentials were mentioned, including other forms of hemolytic anemia, but no other non-hemolytic conditions with hepatosplenomegaly were mentioned, and the candidate ran out of time. Finally, there was a CNS case where he was asked to examine the motor system in an 8 to 9 year old child. The candidate did not identify the syndrome, but looked at thin calf muscles. He did not see the high arch foot, which was mentioned by his friends who were also in the exam. The candidate did find a high stepping gait when he checked the gait and suspected a foot drop. Skin was normal and the child wore thick glasses. The candidate offered CP with ataxia as a diagnosis and mentioned physiotherapy and occupational therapy. He said he stumbled when he was asked about upper motor neuron deficits, and he said that these children will have hypotonia, which is what he had found on the left leg. My personal comment is that ataxic CP will have truncal ataxia rather than limb ataxia, and therefore I'm a little worried on this as well. In conclusion, the candidate felt that even with some lower points, there is a chance of passing. I feel that this candidate will probably either scrape through just above 62 or miss by a few points. But in their previous attempt, they had done really badly, so they are hopeful that whatever it is, it has made him wiser and they will do better this time. That's it for now. Thank you.